And good morning. I'm Dr. R. Duke-Majan with my team here at Duke Spine Institute, Surgery Center Viera. Getting ready to perform spine surgery. We'll be broadcasting live. It's April 25th, 2023. And our first patient today has herniated discs, as you can see at the bottom of your screen, L2-3, L3-4, L4-5. They're herniated on both sides. He's got leg pain on both sides. That means the nerves are getting affected on both sides. Therefore, we're going to be treating both sides of his back. And the way we're treating him is with the newest, most advanced spine surgery in the world. It's minimally invasive, endoscopic. There's no need for fusion because we're not destroying his spine going in. You know, we talk about fusion and instability of the spine. What creates the instability of the spine is not the actual disease, it's the surgeons when they go in to treat it. And there's no need for creating instability when you can do things transforaminal where you're going through natural openings in the spine. All right. We're going to go through a natural opening called the neural foramen. Very good. So we've got our X-ray image, which you can see. And this looks like a pretty good starting point. I may want to start a little bit higher. So we're going to start a little higher, and I'm going to try to access 3 discs with this one incision. And that looks like we should be able to do it. So there's L. Let's count the number of discs. Let's show the sacrum a little better first. The way we count discs in the spine during surgery for localization is we start with the sacrum. You can see that big bone at the bottom. The first disc we get to, which is an empty spot there, is L5S1. And then that would make the bone above L5, then L4, then L3, and L2. And we're going to be fixing L2-3, L3-4, L4-5 from both sides. All right. If you have questions, feel free to type them up and send them to us. We'll be happy to answer them. Num num. I'm going to use some num num, which is numbing medicine, basically Novocaine shot. When I say shot, I'm asking my technician who takes the x-rays to take a picture. It's an older terminology, you can release, when you say shot, but it's one that I've grown up with in my training, and so I use it. All right, looks like we're bumping up against the facet joint there. So I'm going to try to redirect and go a little bit more lateral shot and get around the facet shot. Now our patient comes to us originally from California, where he injured his back. And I'm going to start just a slightly bit more lateral. Shot? Yeah, big facet joints. No doubt about it. Shot. We're going to get around them though. I feel confident. Shot. The key is to just, if you touch the facet like I am, you just keep going laterally until you get around it, like I am right now. So, for those of you interested in learning the technique, notice the position of the bevel. Okay. I'm going around the facet. I've got my bevel pointed that way. So I'm now going to change the orientation and head medially. Let's get an AP. We want to check my position. Now, one other thing, as you go further up the spine, you want to go more medial to avoid injuring things like the kidney. We're going to do an AP shot, which is a front back. Look at the position of the needle there. It's perfect. Now, I was saying earlier, if I wasn't doing endoscopic surgery, I would be doing a fusion. Fusions are far more invasive. Reliable or not, Dr. Berndes?
Hi, friend. How are you? You okay? Try to keep your head still. You doing all right? We're going to ask you some questions, okay, my friend? All right, good. He says he is.
Yeah, good. All right. Yeah, we're well below the nerve root, but I do like to have the patient participating, helping me shot. So I can feel the herniation, and There's our first needle position is perfect. May pull it back just a little bit, just a tiny bit. You want to be right around the middle to front 2/3 of the disc, which is where we are. So if I wasn't doing minimally invasive surgery, I'd be doing maximally invasive surgery, which is the other way to fix this problem. The incision would be this long. Can you see this?
Yes, we can.
That's how long the incision would be. I'd have to make a big incision, peel all the muscle and tissue off the spine, and then remove all the bones and ligaments from the spine. But instead, we're going to make a 7mm 1/4" incision right here, big enough to fit our tube, and that's all we need. That's all any surgeon needs, to be quite honest with you. So these fusion surgeries that are being done today are totally unnecessary, in my opinion. There's no reason to do them. If every spine surgeon knew how to do what I'm doing right now, if they were trained to do it, then patients would not need fusions anymore. Sean? And that's unfortunately where we need to be. So patients don't have to suffer through the pain and agony and complications that happen with fusions. Sean? Fusions are very destructive surgeries. They destroy your body internally. You don't get to see that unless you watch a fusion being done. And I encourage you to do that. AP? I encourage you to go to our YouTube channel and go to our playlists, and then it'll organize all the videos into playlists. And one of the playlists is lumbar fusions. And go and watch a few of our lumbar fusions that we used to do years ago. We've been broadcasting live spine surgery for 10 years now at Duke Spine Institute. 100% every surgery, unless the patient says no. We've been broadcasting live all of our surgeries. So you can watch a fusion and see how destructive it really is. We have to take out the bones, the ligaments out of the spine. And that creates a lot of scar tissue inside, internally, and pain for the patient because the muscles ache for weeks, even months after the surgery. All that's avoided now because we're not damaging anything internally anymore. Sean? Now we're able to fix these discs without any internal damage at all. The only thing we're doing is making a cut on the skin. Sean? And after we make that cut, everything else is done with spreading. Sean? All right, let's see here. Sean? I think I was too lateral. And maybe, it just may be enlarged facets. One more? Yeah, let's get an AP and see where we are. So far we've lost about 4 drops of blood, okay? 4 drops of blood. So the other thing about this endoscopic type treatments we're doing at Duke Spine is there's really no blood loss, okay? So we're losing a few drops and that's it. If you do open back surgery of this type, you're going to lose, most surgeons will lose 1,000 cc's of blood, or even 2,000 cc's, which is almost half the blood volume. And they'll have to do what's called a transfusion. Nobody wants a transfusion. Transfusions are dangerous. What kind of problems do people get from transfusions, Dr. B?
You can get bloodborne pathogens, you can get autoimmune response reactions.
Yep.
You can get all
Shot?
different types of cross-match problems too.
Yeah. That's right. So you get...
So bloodborne and immunity is the key.
Uh-huh.
You can get anaphylaxis, which is extremely rare.
Extremely rare.
Yeah. But you
So,
can get it.
so you can get an infection, you can get an allergic reaction, you can get an immune reaction. Shot?
That's called an ABO incompatibility reaction.
Uh-huh. Yeah. Basically, blood transfusions.
You don't want to give blood at any time if you can avoid it.
Exactly. Don't want to give blood at any time if you can avoid it. That's right. And you can by having this surgery done instead, because we've never had to do a transfusion. All right, I'm still banging up against that facet joint. His spine is far more anterior than I thought it would be, given that he's such a thin man. I may have to do a separate incision. Let's take a look on the AP again. seems like we should be able to get around this facet. Sean? Yeah, we're too lateral. All right. Sean? That's a little better. Lateral view.
There's also electrolyte disturbances because the citrate in the blood, the main preservative in the blood, will bind to vital electrolytes, calcium and potassium.
Electrolyte disturbances. Okay, so you get other problems too with blood transfusions, like electrolyte disturbances, I'm being told. All right, shot. Pretty close to where we need to be. Shot. I'm just trying to position this just perfectly. And again, I'm hitting that facet. AP. The first step in the Duke laser disc repair endoscopic surgery to treat back pain and leg symptoms from a herniated disc, spinal stenosis. The first step is going to be placing our needle. And that's what we're doing right now. It's a big osteophyte there, huh? I need a lateral view. Mm-hmm. Interesting. Yeah. Oh, there, shot. Are you awake?
How are you doing, my
I
friend?
found a little hole.
Okay.
Any pain? Shot?
You doing okay, my friend? Any pain? He said no. Shaking his head no.
Shot? Where do you feel that? AP? I may have to go and do a separate incision for that one because there is some bone there.
Are you having any leg pain?
Just a
He
quick
said
AP.
no leg pain. No leg pain.
All right, you're doing fantastic. We're so close. Almost done with the left side getting positioned. Then we'll move to the right side. All right. So, on the AP view, it looks pretty good. Shot? On the lateral view, I feel like I'm a little higher than I should be. Where do you feel that?
Where are you feeling it? In your back? He says he's feeling it in his back.
Well, we're right there. Let's see if I can wiggle us in. Yeah, the wiggling method worked. All right, so we're done with the left side access. So just take a look here, folks. The whole surgery will be done through a 1/4-inch incision. Henry, you see that?
Yes, we do.
So far, we've lost about 10 drops of blood, maximum, maybe 10 drops, which is half of a milliliter. Remember, most surgeons doing the open back surgery would lose 1,000 to 2,000 milliliters. We're going to lose, so far we've lost half of one. All right. We already did, but if I have to give more, I can. It's not a problem. I numb both sides. Let's give some more num under. Shot. All right, it's not a bad entry point. So at this point, we're numbing the fascia, which has pain fibers in it. We don't want the patient uncomfortable. We try to make the patient as comfortable as possible, but we still need them awake. I need them awake because they're helping me find the right path to their bad disc. You see, there are many ways you can get there, but only a small number are safe. Shot. And that's why I need the patient helping me to get there. Shot. All right, so almost there. Are you awake?
You all right? Okay.
Where do you feel that?
Where are you feeling it? Are you feeling any pain in your legs or
Don't
back?
move your body.
Sit still. Legs or back?
Shot.
He said back.
Yeah, that's where he's going to feel it, is his back. That's what we want.
You're doing great, my friend. You're doing really well.
We don't want it in his legs. Shot. All right, let's get an AP. So when you're navigating the needle, which is the first step of the Duke laser disc repair, you've got to take two views on your fluoro, at least AP lateral, front, back, side to side, and let those views guide you, okay? Some doctors like to position the needle through what's called an oblique view, which is sort of between the front, back, and the side. I used to use the oblique view a long time ago, and then I learned how to do it properly with the front, back, and side to side. So we're in, and let's give a little more num-num. I'm going to numb your skin up a little more, so you might feel a little stick and burn. Don't be upset. That's just numbing you up. Everything's going perfectly well for you. We couldn't go better than it actually is. So the first part of the surgery is this part, which is, to me, the hardest part. The rest of it's pretty easy, because once you have your needles placed into the proper targets, you're going to end up, you know, basically having something very special, which is a path, a way to get from out here to the herniation. And we're actually passing through tissues, muscle, fascia, and then we're not hurting the muscle or the fascia, we're just passing through it on our way to the disc that needs to be fixed. So unlike open surgery, we're not cutting the muscles, we're not peeling them off the spine, we're not damaging anything internally at all with this surgery. Sean, that's the beauty of the surgery, is it's less invasive, meaning less trauma to the patient's body. It means they heal quicker. The healing time for the surgery is literally 24 hours. In 24 hours, this patient will be driving, shopping, walking, working, doing whatever he wants by tomorrow, this time, okay? Now, there is some restrictions until the discs are completely healed. We don't want the patients lifting heavy things or playing contact sports. So there are some activity restrictions just to prevent him from re-injuring the disc. But from a recovery from surgery standpoint, there's no restrictions. He can go back to work, he can shop, he can drive a car, he can go out to eat, you can do anything you want. Just you have to limit the lifting and physical activities for a period of time. All right, let's show our audience the video on why do people get pain from a disc injury in the first place. What is it about the disc injury that causes pain? Sean?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. Now you understand from that educational video why do people actually get back pain from a herniated disc. It turns out herniated discs cause around 85% of back pain. We've done this study in our group at Duke Spine. We're looking at 5,000 patients that had back pain and neck pain. And it turns out right now we're almost done with completing the data review from the files of the patients. We have about 85% of lower back pain, chronic lower back pain, is due to a disc herniation, okay, which needs this surgery to fix it. The other, another 10% of lower back pain comes from facet joints. And then the remaining 5% comes from things like the SI joint, the piriformis muscle, and the coccyx. So 85% chance your pain's coming from a disc or 2 or 3 like this patient, and 10% facets. Now some people have a combination of all 3, so you just have to figure it out for every patient. We are now in position with our needles. Let's show the lateral view. You guys see that?
Yes, we do.
All right, show us the lateral view, 6 needles. Go ahead, Jordan. We're gonna point these out, so stay on the x-ray. 1, 2, 3, 4, 5, 6. Now look where the needles are going in. Go to the middle one. There's a hole in the side of the spine. Show us the hole. It's called the neuroforamen. It's a big white area. And we're entering the disc. Show us the disc where we're entering. Yep, right there. No, that's the whole disc, but show us where we're entering the back of the disc. We're entering the back of the disc right where the herniation is. So we're not actually damaging the disc. We're going through the damaged part of the disc. So we're not creating new damage. We're actually going through a very big damaged area with a tiny needle. And we're going to come into that same area in a moment. As we proceed through the surgery, we're going to come in through that area using our tools, our instruments, okay? So there's no actual damage done. So let's trace the path from the skin. So from the skin, we penetrate the skin through an incision, 7 millimeters, 1/4 inch. That's the only damage being done to this patient's body, 7 millimeter incision. Unlike open back surgery that destroys everything from the skin down to the spine. We're going to just pass through the muscles with the needle. Show us the muscles. That's the muscles, not just there, it's all the way down to the facet. So from the facet to the skin, no, you're just trace with the arrow from the skin to the facet. That whole path is muscle. No, not that far, right there. Now go back to the skin. From there to there is muscle and fat in the back, okay? So we're passing through the muscle but not damaging it. Then we get to past the facet, right there where we enter the foramen. And there's just an empty space there we're passing through. And then we enter the disc right where the tear and herniation are. So we're not actually causing any damage with this surgery. With open back surgery, laminectomy, discectomy, fusion, artificial disc, they're doing massive damage inside your body, which is why there's so much pain after the surgery. Patients have to take painkillers. You have to take painkillers because the surgeon is damaging the inside of your body. And that's permanent, folks. We don't give our patients painkillers after surgery. They don't need it. We're not damaging anything. All right, so let's get started. We know this patient's had pain. How long have you had back pain, sir? How many years? When was the injury?
Sorry, say it again a little louder. 2018.
All right, so his accident was either 2018 or 19, I'm not sure. But it's been what? How many years is that? About 4 or 5 years? Yeah, we don't know exactly, but 4 to 5 years he's been having lower back pain. And the leg symptoms,
How long have you had leg problems? Leg symptoms? Last 2? Last
2 years.
leg
All right.
symptoms.
So there you go. Here's his history right here. I know that Henry's put it up on the board, but we've got back pain since the accident that he had, and legs pain started about 2 years ago. Not uncommon. We see the back pain start first from the herniated disc, and then the legs start to get involved as the herniations get worse over time. Now he's got 3 discs. I asked him, where is your back pain? And he pointed to this area right here. Okay, and I said, well, do you have pain here? And he said, yes. He said, where else do you have pain? He pointed here and he pointed here. Well, there are 3 discs in here that are damaged, L2-3, L3-4, and L4-5. They all have tears and herniations on both sides, okay? So that's where I believe his problem is coming from. We're going to confirm that. We'll take our first question while we set up.
Our first question comes from Trust on YouTube,
Hi, Trust. Welcome back.
and they asked, does Duke Spine Institute do surgery on other body parts or only the spine?
Great question, Trust. We treat the spine, but we're going to start providing our special rhizotomy procedure called the Duke plasma rhizotomy. We're going to start providing it to other body parts like hips and knees. So if you have hip pain, knee pain, you don't need to have necessarily an artificial hip put in. You don't have to have major hip surgery. We might be able to fix it with our Duke plasma rhizotomy. That's going to be our goal. Currently, we do treat hips and knees, but with shots. We don't do surgery on hips and knees. We do spine surgery and we do all spine care. But thanks for asking. All right, are you comfortable?
Yes, you said yes.
I need you to lay still for me, okay?
Still keep your head still.
Let me know if you feel any pain, and if you do, I want to know how bad it is on a scale of 1 to 10. How bad is that on a scale of 1 to 10?
8.
That's the highest it went, was 8? All right, so at L2-3, I just did the discogram. Show us the discogram. Look at the x-ray here, Henry. You can see that I filled the disc with some dye. There's a tear in the back. You see a double herniation shadow. There's one there, there's the other there, double herniation, one on the left, one on the right. And he had 8 out of 10 pain. Is that where you typically get your back pain? Yes, so we call that concordant, all right? See why the patient has to be awake, folks? There's 2 reasons. One, to help me get safely past the nerves into the herniation. And number 2, we want to know about these discs, whether they really are the cause of his pain. And our patient is very patriotic. You could see red, white, and blue. You guys see this over here? Red, white, and blue. Colors of the American flag. All right. Is that better?
Feeling better?
You awake?
Feeling better, my friend? He said yes.
All right. You having any pain now?
No.
See, no pain. So when you do a discogram, it's evocative. See that? He tightened up. Look at that. How bad on a scale of 1 to 10? What's the highest?
10.
10. All right. So number 4, 5. Show us the tear. That's a 10 out of 10, folks. 10 over 10 pain. Is that where you typically get your back pain? Right? So he said yes. So what do we know so far? Jordan is showing you the tear where the pain's coming from. We know that L2-3 and L4-5 are both causing his typical back pain he gets every day. The L4-5 is 10 out of 10 concordant, and the L2-3 is 8 out of 10 concordant. Concordant just means that's my typical pain, right? If I grab his leg right now, he never has pain in his leg, and I twist it, and I create pain, well, that's not his typical pain, because I just created it today during surgery. So that would not be concordant. Concordant means that's the pain they get every day. So it's great when we see concordant pain. It means we're in the right spot to fix his back pain he gets every day. Are you better now? All right, sorry about that. The good news is we've confirmed that 2 of the discs we're fixing today are definitely causing your daily back pain, which means after we fix it, that'll be gone. All right, we're about ready to put you to sleep in just a minute. How bad is that on a scale of 1 to 10? What's the highest? 10?
8.
8. Is that where you typically get your back pain?
Yes.
Wonderful. So L3-4 is an 8 over 10. All right, good news, my friend. You're going to go to sleep now, and when you wake up, we'll be done with your surgery. Okay? Deal? And your back pain will be gone for the rest of your life, as well as the leg symptoms. So, folks, what do we know? We know that all 3 discs that I thought were causing his back pain are indeed causing the back pain. 2 of them were 8 out of 10. 1 of them is 10 out of 10. That's great news. That means we're going to be fixing his back pain with the Duke laser disc repair. Now, some people are saying, well, how do you know where the back pain is coming from? And the answer is we discovered where the back pain is coming from at Duke Spine Institute. And that discovery led us to understand that back pain comes from a small spot in the back of the disc called the annular tear. And everybody with back pain from a disc herniation has that exact same problem, okay? Just like you have 2 arms or 2 legs, 2 eyes, a nose, it's the same for everybody, okay? And we've discovered that during our endoscopic surgeries years ago, 17 years ago, at Duke Spine Institute. That's when we started doing these procedures, 17 years ago. And ever since we started doing the endoscopic procedure like we're doing right now, it hasn't changed much at all. It's pretty much the same way we've been doing it for 17 years. And the results of getting rid of back pain are the same. You know, it'd be interesting to measure as a study the distance from the skin to the disc on every patient, because nobody's ever done that. Nobody's ever done that. And I think we can do it. Right? Can you measure? We can measure on the PAC system, right? We're going to move these DICOM images to the PACs. We can measure on the PACs. All we need is to see the skin. So maybe you can zoom out a little bit, and the PAC system is able to make those measurements, huh? Isn't that incredible?
We have a set distance.
Oh, really? So if I just take this image on the PACs later today and measure, it won't be able to measure it?
If we have the relative distance of what the actual dilator is, we should be able to compare it there. And we'll have to see.
Let's take a look at that. Let's zoom out a little bit, and let's get that skin. Let's see the skin. Maybe just, you don't even have to zoom out. Just bring the fluoro up a little bit. All right, so the skin is turning. Let's see, that's got to be the skin right there, right? Let's see. Right where the Raytec is. Yeah, where they all where they're confluence of the needles. That's where the skin is, right? Yeah. All right, good. So yeah, see those three needles coming together in one spot? That's got to be the skin. That's where they meet and converge. So from there to the spine, I want to measure that distance. So let's bring that image right there over to PACs. And I want to try to measure the distance. Because the reason I'm saying this, folks, is I see people with their spines really up close to their skin, and I see people with their spines really far away. And it has nothing to do with how fat they are. This man is perfectly good shape, and I would have thought his spine would be further back. But it's important because it really does affect the difficulty of the access to the disc. And the further down the spine is away from me, the harder it is to get through the foramen. So it'd be a very useful measuring tool for planning surgery in the future. And I'd like to start looking at that. So on every surgery now for lumbar, let's start getting one shot that we move over to PACs. That is the measurement, the spine measurement, spine distance measurement shot. And let's see if we can figure out a way to make that happen. All right. So there you see it, science and evolution right there. Let's, as I enter the disc with the dilator, he seems to be sedated quite nicely. You can see the dilator is following the guide wire. That's why once you place the needle, you've done your job as a surgeon to ensure safety. I mean, obviously, you want to make sure your needle doesn't go through things like the intestines or the kidney or anything else it's not supposed to. And that's the hard part of the surgery, to be quite honest with you, is making sure it doesn't. Go ahead. And that's what I've gotten really good at over the years, is making sure that the placement of the needle is perfect. That is the hardest part of the entire surgery. Once you have placed the needles perfectly, then the rest of the surgery is easy. Almost, yeah, I'll just say it's easier. My part. Now the anesthesia part, that's a different story, because the anesthesiologist is constantly on his toes, his or her toes, trying to keep the patient safe and sedated. Are you using CPAP?
Yes.
Is it working?
Yeah.
Beautiful. So we started using our CPAP machine, and we're going to do a study on that, right?
Yeah.
So you're going to be the head investigator. You're going to have your name on the paper as a first author. But we need to look at, comparison with CPAP without. Does that make sense? So we can have some data points. All right, we'll take the next question. Yep. Sean?
Next question comes from Canes25 on YouTube.
Yes.
And they ask, Doc, why don't a lot of doctors nowadays use discograms? I feel it really shows the disc tear well.
You are correct. Doctors should be using discograms, but there's a lot of, here's the thing, okay? You guys hear me talk about this all the time. And it's important you understand the truth. And I may go down in history, nobody even listens to me or gives a shit what happens, but the God's honest truth is this. Number one, doctors don't want to fix your pain. They don't. When I say doctors, I'm making a generalization. I do want to fix your pain. Duke Spine wants to fix your pain. Therefore, we've developed treatments that cure pain. But other doctors, 99% of the ones that treat back pain, they don't want you cured. Because if you're cured, their business with you is done. And they're not making money on you anymore. I don't have suction here. So it's the sad truth, folks. You have to come to terms with it, okay? You have to come to terms with the truth. The truth is doctors don't want to fix your pain. Because then you're not going to come back for more shots, more surgery, more treatment. They make money off you. Gosh, you know what, Henry? This is amazing. Look at that granulation tissue. You see it? Henry, I
Yes,
want
I do.
pictures of this. I'm gonna, let me see, I'm gonna stop the flow for a second. Let's start getting, let me just get the focus a little better. Right there, I think that's the best I can do. Hold on, let's get some pictures of this. I wanna put this in our paper.
Copy
Sean,
that.
take a picture. And I'm gonna stop the flow in a minute. Tell me once you've gotten about 5 pictures.
Got it.
Let me bring the laser in too. All right, and then we'll capture the laser zapping it. But let me bring the laser in for scale. Ah, that bubble. You ready? Hold on, it's coming. And I'm gonna want these pictures. Go ahead and get some more pictures. Tell me when you've gotten 3 more.
Got it.
Good? All right, now I'm gonna shut off the flow. So I get ready to take a picture. Oh, air bubble. Try that. That might be a better picture. Hold on, let me get rid of that air bubble. All right, try that. Ah, it's coming from the other side. All right, try that. How about that? Is that a good one?
That's good.
All right, are you ready for me to laser this thing?
Yep.
All right, so get ready to get a little video because this is going to be a good one. Are you guys ready? So this is going to show what the laser does to granulation inflammatory tissue. I want to put this in our paper, okay? So it's very important. This is a very important one. Shoot. Well, I'll just do bursts because it creates bubbles. You see how the laser got rid of that red stuff? All right, that's probably good for the snippet for the video. Okay, so getting back to answering the question, I'm sorry. The truth is that doctors don't want to fix the pain, number one, okay? I don't know if I answered the question for you entirely. There was another reason. Can you repeat the question one more time for me? So I make sure I answer it completely.
Why don't a lot of doctors nowadays use discograms?
Right, discogram. So there, that's number one. Number two, here's another big reason. Insurance companies, they know that if you're doing a discogram, you're getting ready to do surgery. They don't want surgery. Surgery is expensive. It's $150,000 on average they're paying for a spine surgery that addresses a disc problem. Because most doctors that fix disc problems, they're doing a fusion. Okay, they're doing a discogram so they can do a fusion. Fusions cost insurance companies money. So they're smart. So they've made discograms experimental. That's what they say. They're experimental, investigational, unnecessary. And by doing that, that means the doctor doesn't get paid to do the discogram. So doctors aren't going to do a treatment on you they don't get paid for. So there you have it. That's why discograms are not used more, because insurance companies are trying to discourage their use because they don't want to pay for the fusion surgery that's happening afterwards. So by denying a discogram as experimental, then doctors don't do it because they won't get paid. And the patient doesn't get the benefit. Listen, I am in the process of literally fighting for you guys on a huge national level fight that's going to come out in the newspapers very soon, probably in the next year, that we're going to be taking on the big insurance companies for our treatment, okay? Because a lot of them deny it. They don't want to pay for it. This patient's insurance is paying for it. And he's from California, just so you understand. And his insurance realizes, hey, the alternative is a fusion, okay? And a fusion is a far more costly to the insurance company than the Duke laser disc repair. But this insurance that he has is absolutely obligated to pay for it. There's no way out for them. No way out. They must pay. So when an insurance company is forced to pay, that's when they are looking for safer and cheaper ways to fix people, okay? And I can't go into a lot of details about it because, you know, there's legal stuff going on, and I can't spill any beans here. But I can just tell you this. Insurance companies that are forced to pay for people's back and neck injuries, those are the ones that love our procedure because they recognize number one, it works. So if it works, they're not going to have to pay for more treatments. And B, the patient, they have no way of getting away from paying from it. So they're stuck paying the bill no matter what. So they're going to look for treatments that actually work and that are less expensive and result in less impairment, okay? That's all I can say. There's a piece of herniation there. So more doctors should use discograms if they're not sure of where the pain's coming from. I used to use discograms more in the beginning, diagnostically, besides the surgery, like before surgery, just to confirm the diagnosis. That was before I understood how prevalent discogenic back pain was. But now I know the truth. After all my years of experience, I know the disc is the cause of back pain 85% of the time. So for me, when somebody comes in saying I got back pain, I just say, put your finger on where it hurts. And they'll show me exactly where their pain's coming from, okay? That's because the pain sensors in the disc, they go to your primary somatosensory cortex, which is a highly localized pain center. It literally knows exactly on your body where the pain's coming from. It maps it perfectly, which is why these people have such sharp pain, okay? But nobody wants to acknowledge that. And neurosurgeons, they don't know that you can fix back pain with surgery. They don't believe it. They've never been taught it. They're taught just to unpinch nerves, which fix leg symptoms or arm symptoms. But they've never been taught to treat back pain. So they've always sent their back pain patients over to pain management. Well, the pain management doctors don't know what to do. They can just do shots, epidurals, facet blocks, rhizotomies, RFA, pills. They do treatments, therapy. None of those treatments work, okay? They all give temporary relief. If you talk to anybody that's had those treatments, you'll never find a patient out there that says, oh yeah, I was cured with an epidural. No, you weren't. And your pain's coming back. I got news for you. It's just a matter of time, okay? So what we've learned at Duke Spine is why waste people's money, time, and risk doing procedures that don't actually cure problems when we have a cure for each one of them. For a disc problem, it's Duke laser disc repair. For a facet problem, it's not Duke laser disc repair, it's Duke plasma rhizotomy. So depending on the source of your pain, we have a different treatment that will cure it. But if it's the SI joint, then we do an SI sacroiliac joint Duke plasma rhizotomy, and that will cure that SI joint pain. So now we've got literally a cure for every single cause of back pain. And if you have piriformis syndrome, then you do a injection, and then you do a myotomy, where you literally cut the muscle in half, and that takes care of the pain. So the point is, it doesn't matter what's causing your back pain, it can be cured. It just needs the right diagnosis as to the source. All right, let's take the next question.
Next question comes from Truth Always on YouTube. And they asked, what can be done about grade 1 anterior listhesis, L4 through 5, severe disc generation with vacuum disc and advantage height, spinal canal?
Yeah, you can stop now, all right? Truth, this is what you do right here, this surgery, okay? This surgery is going to fix the pain and symptoms from those discs, period. Will it fix your listhesis? No, it won't. You don't need it fixed. Will it fix your dehydration of the disc? No, it won't. You don't need it fixed, okay? There's lots of things in your spine you don't need fixed. People are just so obsessed with the MRI findings, they don't even understand the real cause of their pain. That's not the cause of your pain, okay? If you live out in the mountains and you're starving in a cabin and you're away from civilization, Is the snow the cause of your pain? Nope. Is the ice the cause of your pain? I mean, your hunger? Sorry, is the snow around your cabin out there in the woods, is that why you're starving? Nope. Is the fact there's ice outside the reason you're starving? Nope. Is the fact that there's cold temperature below zero the reason you're starving? Nope. The reason you're starving is you don't have any food. So how do you fix that? You get food. How do you get food? Well, you got to go hunting. You got to go fishing. You have to find food. So what you're reading on the MRI, degenerated disc, spondylolisthesis, dehydration, those are all absolutely unimportant. They're part of the overall picture of what's going on, just like the snow and the ice, but it has nothing to do with the fact you're hungry, because they aren't food, and they have nothing to do with your food. They just make your food harder to get to. So the fact that you're starving has everything to do with the fact you don't have any food, not the fact that it's snowing or icy or cold outside, okay? Or that you live remotely. So those findings on the MRI are absolutely unimportant. They have nothing to do with your back problem, okay? Your back problem, if it's pain, this is what you need done.
We have another question.
Uh-huh.
This comes from Carlos on YouTube. And they asked, hi, I am 35. DX is lumbar foraminal stenosis. I feel tightness, tingling in my left leg, no loss of strength. Is this surgery effective to remove the symptoms? My doctor doesn't guarantee surgery will fix it.
Yeah. So thanks for asking. And yes, you're correct. Your symptoms in your leg are from spinal stenosis. That is correct. Narrowing, causing those symptoms. Yes, this surgery would fix it. And we'd be even willing to guarantee it for you, okay? Duke Spine Institute offers a guarantee. Not everybody gets the guarantee because you have to pay the full price for the surgery. No discount, okay? But we're the only spine center in the world that will guarantee. And what the guarantee means that if we don't fix your leg symptoms with our surgery, that we will do more treatment for you until it's fixed. Can it be fixed? 100%, yes. It can be. It can be. It just requires surgery to fix it. And this is the surgery we would do. And this would fix it. We've never had a patient where it didn't fix it. And we've done thousands of these surgeries. We've never had a patient where it didn't get fixed. So if it didn't get fixed with this surgery, the backup surgery would be decompression and fusion, which is a $100,000 surgery. But we would do that at no cost to you if indeed you get the guarantee that we offer, okay? So yes, this surgery would work. You don't need the guarantee, but if you want a guarantee, we offer it. And all you need is this surgery right here. I don't know how many levels of stenosis you have. I'd need to review your MRI. You're welcome to use our free MRI review form, which Henry will type right now and put it on the onto the chat box, yeah. So you can see it. But just click on that, send in your MRI. It's going to ask you some history. You know, where's your pain? How many legs? Which leg? So just the basic questions. And then Sam will get your questionnaire that you filled out, and she'll get your MRI once you upload the images, either upload it onto our website. We have a portal. You can upload your DICOM images from a CD onto our portal, or you can send us your MRI images and report on a CD and just mail it from FedEx, UPS, etc. But not email. Email doesn't work, okay? So we don't do the email thing. Not to my knowledge. Could be wrong about that, but I think it's too big of a file for email. So maybe Dropbox or something like that. But anyway, long story short, happy to look over your MRI and happy to advise you on the best treatment. A lot of our people that contact us, they think they have one bad disc. They end up with 2 or 3 that are causing their symptoms. And The reason they think they have only one is because their surgeon tells them they only have one that needs to be fixed right then. And the reason the surgeon does that, surgeons don't want to do 2 discs or 3 discs, even though the patient needs it. They want to do 1, because that way they can make more money on you, making you come back for 2 or 3 surgeries. We do everything here at Duke Spine in 1 surgery, so that you don't have to keep coming back. Now, sometimes our patients do come back because they have a different problem, but they never come back because they have the same problem at a disc that we've already operated on. Does that make sense? So you, as a patient, what you want is a doctor who's going to go in and fix everything in 1 shot. You don't want to have to keep coming back getting more surgery. That's the worst thing that can happen to a patient. I was a patient. I'm a patient as well. When I had my sinus surgery, I went to a doctor I trusted, but he took me 3 surgeries to get it right. And I'm not happy about that. But at the same time, I didn't have a complication, so I'm grateful that I survived the surgery and that it's working pretty well. It's for my sinuses, okay? I don't have a problem telling you guys that. But the point is that if you don't have to have 3 surgeries done, it's better to do 1 and you're done. And that's what we do at Duke Spine. We figure out where your pain's coming from, and we do 1 surgery that treats all the discs. Just like this here patient right now. Okay, he's getting 3 discs repaired on both sides. That's a huge surgery. But we're going to get it done anyway, because it's the right thing for the patient. That's what we do at Duke Spine, what's right for the patient. All right, just about done here. I need to take a look. There's a little piece of connective tissue. I want to try to get around that. You guys can see the fat at 12 o'clock, right? Now what's interesting, at 12 o'clock, sometimes you'll see the facet joint there, if it's enlarged really bad anteriorly. In his case, there is some facet joint enlargement, but it's not so bad as some of the ones we've seen. The facet joint would be right there where that fat is. All right, very good. So we're just about done, 10 seconds, maybe 20 seconds max. Don't forget to get the lateral herniation here in the foramen. You know, some doctors don't know to do that. All right, beautiful. Now let's see if we can see the nerve root. Nope, it's buried in fat. But that's Cambin's triangle right there. Parvis Cambin, the originator of the transforaminal approach, endoscopic. He's from the university. He's up in Pittsburgh. I think he passed away, but he was actually an Iranian doctor, orthopedic surgeon. He was the one who came up with this approach that we use, to give him credit. Okay. Yep, done with 1. Moving on to number 2. We're going to put some betadine as an antiseptic. We've never had an infection. 1,600 of these surgeries, no, not 1 infection. That's special, folks. I don't know if you know that, but spine surgery gets infected all the time with open spine surgery. We don't do open spine surgery, we do endoscopic. So we've had 0 infections. From a patient safety standpoint, that's what you want. You want a surgery that's not going to cause an infection of your spine. Open surgery, laminectomy, discectomy, fusion, artificial disc, they all cause infections, horrible infections. And whether or not you're going to get an infection is like a crapshoot. You know, you just never know who's going to get an infection. And the reason is that the surgeons don't know who's going to get an infection.
It's a large open wound that's open to air along
Right, yeah. So I can tell you right now, you want a surgery that won't infect you, and this surgery has never infected a single person. All right, next question.
This next one is a comment from John Smith on YouTube. And they said, "Hello from Australia. I'm very interested in you looking at my MRI and scans. Loving your work. So sad that your treatments aren't done worldwide."
This one right here, though.
Yes, first of all, thank you for your comment. And yes, our treatments will eventually be done worldwide. The problem is honestly just money. It takes a lot of money to, build a surgery center like this. We have a small center. If you've ever been here, it's only 20,000 square feet. We do everything out of the center. It's a combined doctor's office plus surgery center. And, we've got literally over $10 million to build this building and a few $1,000,000 to buy equipment. So you're talking about a 12 million to 14 million US dollar investment just to build a small center like this. And to build these centers worldwide is going to be so, and by the way, that's just the cost to set it up. To maintain our center, or minimum $500,000 a month, okay? So there's huge expenses to maintain it, to pay all the staff, to pay for the supplies, equipment, licenses, everything. So they're very expensive to run these centers. And that's why this procedure is not available worldwide, is that it's so expensive to set it up, and it's so expensive to do it, you know, to keep it going. That to have all those centers everywhere would be wonderful, but unfortunately there's no money for it, you know. I'm not a big hospital system. We're a small company, very small. We have 70 employees. We're all located right here in Florida, and we don't have billions of dollars coming to us. We get no money from donations. We get no money from grants. It's just basically insurance and patients. So I agree with you. There needs to be this procedure worldwide for everybody to get out of pain. It's incredible. If I could, someday it will be, okay? But I'll be honest with you, it's so hard to get the word out. We go on YouTube, we go on Facebook, and they all want money to spread the word. Yeah. They want us to pay, you know, to promote the videos, to boost the videos or boost the Facebook. And that costs tons of money, and it would have to be passed on to our patients. So it's sad that the way people get their news today is through social media, but social media doesn't like reward discoveries and good things that help people by promoting it free of cost. They make the person who's trying to, you know, who discovered it, they make us pay a lot of money just to get people to see it. So I think there should be, personally, I think that when it comes to people's health and well-being, that news should be shared on social media freely and promoted freely by Facebook or YouTube or whoever the social media platform is. But that's not reality. So the reality is that it's just very expensive to do these surgeries, and it's expensive to get the word out. So yes, I think until we get more money coming in and more awareness of that this surgery and treatment availability, that we're going to have limitations, unfortunately. And all the promoting you see me do with, you know, broadcasting, I pay for this out of my own pocket, okay? And I pay for it because I believe that people out there that are suffering shouldn't be suffering. They should have a way to get out of pain, at least available to them. And this is available to you, even though you're in Australia or wherever you are around the world, it's still available. You have to get on a plane and come here and get it done, but it's still available. So as long as we have one place, it's still available. I would love to have more locations. Trust me, I would, but I don't have the money for it. We don't have we don't have venture capital money. We don't have private equity money. We don't have government money or support. We have, you know, the problem is to get government money, you need to be corrupt. You need to do unethical, immoral things. If you want the military, if you want the United States government, military, to take this procedure and support it, you've got to bribe politicians and generals and administrators. You got to bribe them, like literally millions of dollars. I don't have the money to do it. I'm not interested in doing that kind of stuff, okay? To get the insurance companies to pay for it, you have to sue them, which is what we're doing, okay? To get you know, money from Bill Gates Foundation, God only knows what you have to do, okay? I don't know, but there's a Bill and Melinda Gates Foundation. They're supposed to support medical research and medicine and advancements in medicine. We've never gotten a single peep from him. And it's hard for me to believe the foundation doesn't know we exist. Huh? Yeah, they're really not charities. So you use their charity as a vehicle to make more money. You know, it's all for profit. So I'm not paying him any money, so he's not going to give any money to us to help people. So all these charities you see that are getting benefits of being a charity, they're not really helping people. Okay, if they really want to help people, they would come to Duke Spine, they would set up $100 million, put it in a bank account, and then take the interest off that, whatever that is every month, and they would use that money to fund people's medical care, to get out of pain. It's all mostly sham nonsense out there. Robotics and surgery, complete nonsense. Okay, and there's lots of private equity money. There's lots of VC money going into robotics. Robotics is garbage. Okay, it's just a scam. It's a company that came up with an idea, let's use a robot, it sounds sexy, and let's get some money from these investors, and let's just try to sell more robots that are totally unnecessary. Literally, we do the best surgeries in the world on the spine. There's no robot that does a better spine surgery than me. And why can't surgeons just become more competent at doing spine surgery themselves? Is there a need for a robot? No. Is there a need for an MRI? Yes. Is there a need for laser? Yes. Is there a need for endoscopic equipment? Yes, obviously. But there's no need for a robot. Okay? And so what's happening now is these initiatives in medicine that you see, whether it's robots or it's, labs being done, genetic testing, whatever, these initiatives, their whole purpose is to trick investors into paying money for them, and then they get that venture capital money, and then the project falls on its face and goes nowhere. Look at what's happening at the VA right now. The VA just announced, literally, this is shameful. The Veterans Hospital of the United States, the one that doesn't have enough money to pay for the vets to get medical care, and all these vets are sick and dying from diseases that are completely curable and treatable. Well, there's no money for the medical care, but there's money to spend on a medical record system, a software. So they hired Cerner, agreed to pay, $2.5 billion for a medical record system, piece of software. Well, Cerner, of course, knew they were never going to they were never just going to take $2.5 billion from the VA. They set it up so that they could squeeze more money. So the last number I heard, the VA is going to pay $25 billion for their Cerner medical record system. Over the last 10 years, the number keeps climbing. It's just a scam. It's like hiring a contractor to do some work on your house to fix your bathroom, and they say, I'll do it for, $10,000, and then they come back and say, oh, you got this other problem. I need $12,000. And then a week later, they need 15, and then a week later, they need 20. And pretty soon, you're up at $100,000 to fix your bathroom, which was supposed to be $10,000. It's just a scam, okay? The contractor is just milking you. And that's what Cerner is doing to the VA. They're up at $25 billion right now. I don't know about you, but that's a lot of money to me. So the VA just decided this week, fuck you, Cerner. We're not going to pay for your medical record system. And they literally just abandoned, after spending billions of dollars on a medical record system that's literally no better than doctors handwriting in a chart, which is what I do, by the way. I handwrite in my chart. So it's a scam. There's all these scam initiatives in medicine. Okay, and you talk about the United States spending more money than any country in healthcare. It's all going to the wrong people. It's going to these greedy corporations that are trying to sell things in healthcare that have political ties to politicians and lawmakers who make laws saying that these things are necessary when they're really not. And none of it's actually going to patient care. And Americans are so duped by this, they have no clue what's really happening. And I try to tell them, through my broadcast, happy to talk about it, okay? But all that billions and billions of dollars in healthcare are not going for patient care. It's going to insurance companies' profits. It's going to politicians. It's going to electronic medical record systems like Epic and Cerner, going into their profits. Judy Faulkner, she's the one who discovered Epic, right? Founder of Epic Medical Record Systems. She's a billionaire, a multi-billionaire. Why? Because profit from those systems. In other words, overcharging. It's completely disgusting that patients are not getting medical care they need, and instead the hospitals are spending billions of dollars on medical record systems like Epic, making Judy Faulkner one of the richest people in the world, and she's just one stakeholder at Epic. There shouldn't be, folks. There shouldn't be that much gravy on the sale that hospitals don't have enough money to keep their doors open, and yet medical record companies like Epic are just making bank. Our country is so screwed up in its priorities in healthcare that it's like a parasitic fest on all the money and resources in healthcare, and none of it's going to the patients who need it. So, why isn't this surgery more widespread around the world? Greed. Corporate greed is really what it comes down to. And I can't fix that. I can't. You guys have to fix it. I talk about this a lot. I put the blame all on you, the public. All right, I'll help make you aware of the facts, but you guys have to rise up and do something about it. I can't do it alone. I've already discovered the cures to back pain, neck pain. That's enough for one person in a lifetime. But, you want me to fix the corruption in our world? I can't. I can expose it, but I can't fix it. That's going to come down to the general public doing something about it. Most importantly, hold your politicians accountable. Number one, take away the insurance company's ability to deny paying for treatment. That used to never be in place. That's something new. That's something new in the last 20, 30 years. They've just increased denials. Denials that are at an all-time high. Insurance companies not wanting to pay for care. So if you get rid of the insurance company's ability to say, no, we're not paying, then more money will flow into the hospitals and doctors, and they can take that money and invest it into building more medical practices, more facilities to treat patients. That's the answer, my friend. That's the only answer. But we're far from it, and just getting further and further away every day. All right, next question. Just about done with this number 2 out of 6.
Next question comes from Trust on YouTube, and they asked, does bone spurs cause herniated discs, or is that not related?
Yeah, bone spurs do not cause herniated discs at all. Bone spurs occur on a herniated disc in some patients. They're the body's effort to stabilize painful movement, and it's from mostly inflammation. You guys see the tear right here I'm working on? That blue stuff shouldn't be in there. That came from the center of the disc way down here, and it's squeezed out. That's extruded nuclear material, extruded disc. And that blue stuff is causing inflammation within the annulus. That inflammation in the annulus is what causes the bone spurs. So the bone spurs are not important. They're rarely ever the cause of any symptoms. We can get rid of them when we need to with the laser, but most of the time you leave them alone because they don't do anything. It's misinformation. You guys are being told something that isn't true by your doctors. But bone spurs scare people, and so doctors use it to their advantage. They say, oh, you got bone spurs, and then people go, oh my gosh, bone spurs, sounds bad. Yep, you need surgery, you need a fusion. You need an artificial disc, you need a laminectomy. So doctors use bone spurs to scare patients into surgery. I rarely ever have to take bone spurs out, and I never do surgery for bone spurs. By the way, you should know that. Never have I done a surgery just for bone spurs, because they don't cause problems. It's the herniation that causes the problem. All right, just about done here. Another 30 seconds, and we're going to move on to the next disc. Great questions from the audience today. I appreciate you all asking. By the way, there's a bone spur right there. You guys see this? Right here? Okay? It's nowhere near the nerve. It's nowhere near the nerve. The nerve is way over there on the other side. Now, when I say way over, of course, we're talking about, 5 millimeters? But it's still far away and it doesn't cause problems. But just to give you some perspective. I leave bone spurs all the time in there, and I still cure people's pain. I just want to get all these broken up pieces of nucleus out. You can see the end plate right there. That pink thing is the bottom of the bone of the vertebral body, in case you're wondering. This is still annular tear. I'm debriding laterally. Looking good. One thing I'm a little surprised, we haven't seen the needle from the other side. Usually when we have a double, are we okay?
Yeah, I'm just checking the openers.
Thanks. Maybe we'll see it now.
Do a little survey.
So great. Oh, there's the needle right there. You guys see it?
Yes, we do.
Right there. There's the tip of the needle. Pretty cool, huh? So we're going to be coming in on the other side to fix the rest of the herniation on the opposite side. All right, 10 seconds on this side. I should be done. Just want to make sure I get all the herniation I can. This is a pretty big surgery. It's six areas or 6 spots on the discs that we're fixing. That's as much as we can do in one surgery, and I want to make sure we do it right for this patient. I want him happy and out of pain. Just about done. By the way, for reference, the laser fiber you're seeing, that glass part is 1 millimeter. 1 millimeter. Sorry we talk in millimeters, but that's what these tools are given to us in their dimensions, millimeters. Just about done. Let's see if we can see the nerve. Hey, let's see. I may need to get that right there. That looks like a little piece of annulus that's sticking up against the nerve. The nerve is just above that annulus there. Can't really see it. It's hidden in the fat within the foramen. But it's right there, literally, just inside that fat right there. And that would be your left L3 nerve root. We're done. So, looks good to me. I'm happy with that. Scope off, please. We're going to put a little antiseptic, which is betadine, developed at NASA just down the road. I actually watched the Hubble program last night. I don't know if you guys have seen that, but there's a movie called Hubble, the Hubble telescope, obviously, and it was filmed many years ago. I think 2009. Almost 15 years ago, they were filming it, and it was about the rescue. How the astronauts went up with the space shuttle and had to do repairs to the actual Hubble. But it's incredible, the pictures, if you've never seen the pictures, and it really gives you a perspective of the world, life, the universe, time, space. I mean, based on the Hubble's images, there are, I can't remember the exact number, but I want to say 500 billion galaxies out there. Almost a trillion, no, 100 billion galaxies, sorry. 100 billion, all right, 100 billion versus 500 billion galaxies, I mean, there's not much difference there, right? It's just an astronomical number, and conceptually a galaxy is so big. Just to give you reference, the world is in the Milky Way galaxy, which is a smaller galaxy. But the amount of matter in the universe is so vast that it gives you perspective on how insignificant we truly are as human beings on Earth. It gives credence to the lyrics of the song Dust in the Wind. It's all we are is dust in the wind. It's true. So if your head ever gets too big, just remember 100 billion galaxies in the universe that we know about. pretty much confirmed by Hubble. Great program, though. If you've never seen it, I recommend watching the movie Hubble. It's a really good movie. Very educational. Okay, coming down to our, hold on now, our third disc on the left. I have to redirect shot. I got to point my dilator in the right direction there. You see that? How I shifted it a little bit? The good news is we're running right along the guide wire, which we want. We want the guide wire guiding us. That's the whole purpose of a guide wire, is to guide. It's to guide my tool, my dilator. Without the guide wire, we'd be in a lot of trouble. We wouldn't be able to get here safely. With the guide wire, see, we're entering the discs are spreading. Now we're inside the disc. I can feel it. Wait, take that, pull it. So I'm going to remove the guide wire since I don't need it anymore. I'm inside the disc. I'm actually going through the herniation right there. We're going into the herniation, literally. So we went and pushed the herniation back in to the disc. And now I'm going to go take the pieces out endoscopically. Any questions?
Yes, we have a question from Canes25, once more on YouTube.
Shot?
They asked, can't wait to come see you for my lumbar once both all nerve procedures heal. But
Okay.
should I get the ball rolling now so I can possibly get this approved?
Should I get what now?
Should I get the ball rolling now so that I can get this approved? Get insurance approved?
Yeah, insurance is not going to approve your surgery most likely up front. We'll submit for authorization, but they rarely will approve it up front. You're going to just have to get it done, and then we're going to have to submit the bill to the insurance, and then we're going to have to fight them to get them to pay. That's the reality. So no matter what, you're going to have to pay out of pocket, a copay, deductible, and it's going to be not your typical one because we're an out-of-network facility. Yeah. So everybody that gets this procedure, unless they have work comp and type insurance, which pays, agrees and pays up ahead, doesn't pay ahead, but sometimes they do. But we have an agreement signed by them, a contract. If you have standard insurance like Cigna, United, Aetna, you're going to need to get the surgery done before we can bill them and find out if they're going to pay. So it doesn't matter if they authorize and say, yes, we'll pay, or no, we won't. We still require a deposit from every patient to be made up front before you get surgery. It's not the full amount. It's part of the surgery cost, but that's true for everybody. So what you should do is do your MRI review, find out what you need done, and then find out what your out-of-pocket would be. The problem is if your insurance doesn't pay, we can't take that chance. You as the patient have to take the chance your insurance doesn't pay, not the surgery center. We couldn't survive like that. So, and nowadays the copays and deductibles are so high anyway that the insurance usually puts a large part of it on the patient. So you would have to pay some copay, deductible, co-insurance amount up front. And everybody's different depending on how many discs are being fixed and which levels, cervical, thoracic, lumbar, how many sides are being done. So your specific treatment is specific to you. That's why we do the MRI review, because you can't go based on a report. You have to go based on what I believe is the source of your pain, based on your MRI and your physical exam and your history. So I use 3 things to determine what needs to be done: history, physical, MRI, and EMG too sometimes, most of the time. So my advice is do your MRI review, get your recommendation, start saving your pennies for your surgery, for your copay, deductible, and then when you're ready to get it done, get it done. But we're not going to know if your insurance will pay until after it's done, till we submit the claim. By the way, it doesn't matter. Insurances say in your authorization, if you look at the fine print, authorization of your surgery is not a guarantee of payment. They say it on all their forms. If you've never seen that, go look. It's there. So we cannot do surgery without a guarantee of payment. We refuse to do that. We would go out of business, basically, if we did that. So we made a policy years ago that patients have to pay some money up front, at least to help us cover some of our costs. And then we'll bill your insurance for the full amount. So if you have Medicare, Medicare will not cover our surgeries. Medicare doesn't want to pay. The insurance companies that run Medicare, Blue Cross, Cigna, United, they basically get paid by Medicare for denying treatments. So Medicare says, we don't care what you deny, just save us money. And that's what they do. They just deny treatment. And they'll deny everything they can until people scream and cry enough and that they have to do something about it. Okay? They're not going to deny, fixing a brain tumor yet, even though they're trying to do that. Because if somebody has a brain tumor, nobody's that stupid to believe that it's unnecessary to have brain surgery, right? But Medicare's working on that, trust me. Pretty soon they're already saying if you have certain types of cancer, you don't need treatment. It's not medically necessary, it's experimental, that's what they call it. So that's already happening, and many people out there know what I'm talking about. And they're targeting the more expensive treatments, by the way. So for the first time in history, Medicare is now denying cervical spine fusions, ACDF, which is a very common surgery. They're saying it's experimental. I love that. It's funny. It's been around for 60 years, but it's experimental. So, nobody is holding the insurance companies accountable for their lies. And that's what we are going to do. But, again, it takes money. If you want the very best for your body, the safest surgery, the best surgery, you're going to have to invest your money. Because the insurance companies cannot be trusted to do what's right for you. And I've seen them do what's wrong thousands and thousands of times. Laws that they've created, that they had their politicians make for them, that allow them not to pay. You guys voted those politicians in office. So, you have to deal with the consequences of your actions. This means you're going to have to pay more out of pocket than you probably want to until we successfully are able to change what the insurance companies do. All right. Any more questions?
No current questions.
All right, great. Why don't we run the video then on how does the Duke laser disc repair actually work? As we finish up our third disc on the patient's left side, and we're going to move to the right side next.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. the annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. And now you understand what the Duke laser disc repair does, how it works. It's a small incision as opposed to a large incision. There's no removal of your bones or ligaments in your spine, so we're not destabilizing the spine in any way. And more importantly, folks, what matters to you as the patient having back pain, you want to get rid of your back pain. There's no surgery in the world that gets rid of the back pain like the Duke laser disc repair and the Duke plasma rhizotomy. So if you have back pain coming from a disc or 2 or 3 or 4, then this is the procedure you want. You want to avoid open, dangerous surgeries that don't work, like microdiscectomies, mild procedures, laminectomy, fusion, artificial disc. All those surgeries are extremely invasive and they don't really fix the problem of pain. They'll do it for you for leg symptoms, they won't do it for you for back pain. So when you go see your surgeon or talk to a doctor about treatment, ask them, will this cure my back pain? Will this cure my leg symptoms? They'll tell you the answer is no, it's not going to, because none of those other surgeries have the chance of curing back pain or leg symptoms. Typically, people come back with more problems in the future. They need more treatment. Duke laser disc repair, if your problem is your discs, this surgery fixes it. Our reherniation rate is 1%. That means 1 out of 100 patients will reherniate their disc. And they'll come back and they'll say, oh, my pain came back. And it's always related to doing something they're not supposed to do. The good thing is our patients are usually pretty honest about it. Some of them are not. Some of them say they don't know what they did. Then you talk to their spouse and you find out that they were out in the garden throwing mulch bags or building a patio with cement, you know, a week after their surgery, and they felt a pop in their back. So the reality is that reherniation does happen, even with Duke laser disc repair, and it's 1%, 1 in 100. That's our rate. But it's always related to people doing things they're not supposed to do. How's our irrigation? I feel it getting warmer, which means not as much as flowing. Is it good? All right, we're done here. Let's take a look, see if we can finally see a nerve. There's your nerve, folks, right there. See it? And notice the surface is not a nice, smooth white. That's what you should see. It's kind of, look at it, it's very fibrous. It's got like, so it's quite an interesting relationship. Doctors don't know this stuff. If you go anywhere else, they won't be able to tell you that because they don't know that that's what happens. They're just completely ignorant to it. There's so little that has been known in this field, but it all makes sense. I've done thousands upon thousands of surgeries, and I learned these principles as a result of my many surgeries, seeing these things, paying attention, and asking questions all the time. Why? Why do people have leg pain? Why do people have back pain? Why does fixing the herniation in the disc get rid of the back pain when you do the Duke laser disc repair, but not other types of surgery? And the answers, you know, come if you're paying attention. All right, we're done on the left side. Now we have the right side to get to, which is next. I'm going to apply a little bit of pressure. The good news is we did everything on the left side through a small 7mm incision. It's a Band-Aid incision, folks. You're not going to be able to find that anywhere else in the world. By the way, if you go online and you watch endoscopic surgery, there is a very popular type of endoscopic surgery that's becoming popular in Asia and overseas, okay, in China, Korea, India. It's called the UBE, And the problem with that surgery, it's not the same as the Duke laser disc repair. They actually go through the lamina. They remove part of the bone and the ligaments. So they're actually ruining your spine, the normal parts, just to get to the disc. We don't do that here because it ruins the spine. We do a more advanced technique that doesn't damage your spine at all. And the other doctors would do this technique if they could, but technically they're not able to. It requires a very good surgeon to do it, a very good spine surgeon, someone with a lot of experience and knowledge. And unfortunately, this is a harder type of surgery to do technically than the UBE technique. But the good news for the patient is it's better for the patient because there's no damage to your spine. Questions? Pull back the guide wire a little bit.
We have a question from Truth Always on YouTube.
Good job.
They ask, do you work with VA patients or Department of Labor / federal insurance?
Yeah, we do work with VA and Department of Labor. However, they have to pay a deposit for their surgeries up front. And we've not been able to get the VA to pay. The VA is not there to pay for your care. They don't want you to get the more advanced surgeries and expensive surgeries. So they don't make it available to you. Hold on. Let me try a little bit more. So yes, we will work with you, but you're going to end up paying out of pocket for the surgery. The VA system is deceptive. They tell you they'll pay, but they don't. We used to take VA for years, and they would pay the bills. They would pay at Medicare rates, which is not great, but at least they paid. Now, and then about 10 years ago, the VA system said, hey, how can we save more money and not pay doctors and hospitals? And they hired these companies that are just like Blue Cross and Cigna and United. They're called third-party administrators, and what they do is they just deny payments. They look for any reason. Oh, you didn't cross the letter T. Oh, you didn't fill out this blank on this form. Oh, you didn't do this or didn't do that. They give you things like forms and stuff to fill out, like lots of complicated forms that take hours and hours. And you can't even fill it out until you call them and get answers. And then they don't answer the phone. They make you wait on hold for hours. So basically, they've created a system that basically deters doctors from treating patients that are VA patients. And then after you do all that extra work that you don't do for anybody else, then they don't pay you. So we had that happen, I think, with a lot of patients, maybe 20 or 30 patients, and then we said, look, we can't resolve this. It's too complicated. We're not getting paid for what we do anymore. We're not taking this. And that's what they want. They want doctors and hospitals to stop taking VA insurance, because then the vets don't get the medical care they need, and they don't have to pay. The VA system doesn't pay, so they're saving money. And the company that did it, the third-party administrator, they're making money because the VA is no longer paying for those services. So again, the insurance companies have inserted themselves in between the patient and the doctor in a way that's not facilitating care but preventing it. And that's happening all over the United States, happens all over the world, and it's happening more and more every single year. I see it happening more and more. Back in the 80s, it didn't exist. 90s, you started to see it. Then in the 2020s, it's becoming more and more pervasive across different lines of insurance. And it's only going to keep getting worse because people just let it happen. People like you that have VA benefits, you don't go out and fight. You don't get your politicians involved. I've even had veterans go to their politicians, and the politicians do nothing. Okay? So, maybe because it doesn't get to the media. I don't know. But look, for it to go to the media, it takes money. The media is corrupt. The media wants a bribe to cover stories today. So back in the 70s and 80s, the media would cover big stories that were important because he was either right or wrong and something was happening and they want to cover it. But nowadays, the media covers stories that you pay them to cover. They will not cover stories unless you pay them. And the people that pay them are the insurance companies. So the companies with lots of money to pay the media outlets are the ones who get the stories in their favor. How do you think the war on opioids happened? the whole war on opioids in the New York Times and the LA Times and all these news channels, it was all paid for by the insurance companies, okay? The insurance companies like Cigna, United Healthcare, Blue Cross, they don't want people to get narcotics because they're paying the bill. Insurance companies were paying $3 billion a year in narcotic painkillers before the war on opioids. All right, big herniation, take a picture. Let's get lights on. Lights on, you guys see this?
Yes, we do.
All right, let's line it up. That's a good one. Centimeters, inches, whatever. So there's the grabber. I just pulled out a piece of herniation. You can see how big it is, right, Henry?
Yep. Yes, we can.
It's over a centimeter. It's a big fatty. All right, good. We're done. Let's go back. Point is that the media outlets, the news outlets, are now controlled by big corporations like banks and insurance companies, and they have an agenda, all right? And this war on opioids, okay? Opioids have been prescribed by doctors since the 80s. Yeah, I disagree with opioids as a solution for back pain and neck pain, of course, because we can fix back and neck pain. But the stakeholder who has the most to benefit from this war on opioids is the insurance companies, because by law they have to pay for painkillers. Okay, they got to pay for it. It's part of your plan, and they cover them. But now they're not covering them, and all they had to do is concoct this war on opioids story. And prior to the war on opioids in Florida, there were 12. Whoops, I just touched that. There were 12 people every day. Let me see. I think we're okay. There were 12 people every day dying from opioid overdoses, prescription opioid overdoses. That was before the war on opioids. Now in Florida, there's twice as many people dying every day from prescription. I'm not talking about fentanyl on the street or heroin. I'm talking about prescription narcotic deaths in the state of Florida have doubled. They're in the 20s a day after the war on opioids. So what's happened with the war on opioids? Have we fixed the abuse happening? No. But what's happened is the insurance companies now have gotten out of paying for opioids. So they're saving about $2 to $3 billion in expenses a year. And what are people turning to instead? They're turning to marijuana for pain. Now, does the insurance company pay for your marijuana pills or your weed for pain? No, they don't. Why? Because it's federally illegal for marijuana, okay? So the insurance companies know this. The Blue Crosses and United Healthcare, they knew this. They are working to make marijuana legal so they don't have to pay for it. I mean, they're making it legal in the states, but not federally. Okay, it'll always be federally illegal. So the insurance companies have lobbied to make marijuana legal in the states so people like you can get it for your pain and not have to, and they don't have to pay for it because it's still federally illegal. So they're not obligated to pay. So basically they've converted American patients in pain from a pain med they pay for to a pain med they don't pay for. I mean, they're so sneaky and nobody knows this, and I'm the one who figured it out, and I'm trying to tell you guys about it, and yet nobody does anything about it. It's the same thing with surgeons. You show them the Duke laser disc repair, how amazing it is, and they don't do anything about it. Why? I don't know. You know, for whatever reason. You guys have your reasons. But all I can do is give you solutions. You guys have to implement those solutions. I can't do it for you. So now we have people who are suffering in pain. They can't get painkillers. And their insurance companies are laughing all the way to the bank because we're so blind. And we're like, you know, they can tell you, they could sell ice to an Eskimo. That's what insurance companies can do. They can convince an Eskimo to buy ice. That's how they are. They have the best psychologists working for them. They have the best lawyers working for them. They have the best of everything. And their whole purpose is to not pay for your medical care. Whatever it is they're paying for, they want to find a way not to pay. So thank God there's a few good law firms in the United States that are taking them on, but losing, unfortunately, because the judges are also corrupt. The judges that oversee these cases where patients are being denied treatment by their insurance company. They're not being paid for. And finally a good lawyer will go and take on the insurance company, get them to pay. But then they run up against these federal judges that are literally bought and paid for by the insurance companies. So it's a huge problem, folks, and you guys are all oblivious to it. The only thing I can do is make you aware of the truth. In the end, you're going to have to go out and fight the battle yourself. You're going to have to fight, or you're just going to end up, we're going to keep dropping as the world's sickest country, even though we spend the most money on healthcare. All that money goes to the rich companies that are part of the healthcare industrial complex, like Epic, Cerner, United Healthcare, Blue Cross, Anthem, Cigna, Aetna, just State Farm, just huge companies that basically provide insurance that there is no insurance. There is no coverage, basically. Got to stop it from getting worse. So, until then, you're going to have to pay for your special surgeries. You're going to have to pay for the best care in the world. But what I can assure you is that this is the best care in the world. That I know for a fact. All right, 4 down, 2 more to go. We're on our last 2 discs in just a minute. You have any questions, comments?
Yes, we have another question from Canes25 on YouTube.
Uh-huh.
They ask, do you refund upfront fees once one pays?
Yeah, so Haynes25, great question. Does Duke Spine Institute refund the deposit the patients make once we get paid from the insurance company? The answer is yes, we do, as long as the amount paid is over the charge. So for example, if your surgery is $70,000 charge and you paid $20,000, then your insurance company, if they pay $70,000, we're going to give you all of your money back. We're not keeping more than the charge. You know, that would be probably illegal, and it would certainly be unethical. So if your insurance pays the bill, then you're getting back your money up to the total charge. I don't know if that makes sense. Hopefully it does. I try to keep it as a simple explanation. But let's say your insurance company only pays $50,000 on a $70,000 bill, and you paid $20,000, then you're not getting any money back. All right, we may give some of it back, but we're not obligated to. We're not going to. Don't count on it. So basically, if your insurance pays the whole bill like they should, then you're going to be getting all your money back. But if your insurance says, hey, we'll pay $60,000 out of $70,000, the patient has to pay $10,000, then you're going to get a refund of everything except for that $10,000 that's owed. Does that make sense? I'm trying to keep it as simple as possible. But yes, we do refunds, and we do pay patients back.
We have another question.
Yes.
This comes from Truth Always on YouTube once more.
Uh-huh.
And they ask, so approximately what is the cost to fix 2 discs as you are? I'm sure in my case it will be out of pocket.
Yeah. We don't do guessing on costs over the internet. That's one thing I won't do. So I'm sorry. Truth. I'm not going to guess. I don't do the pricing. We have schedulers that do that, and they're not here in the operating room to answer you. So I don't think it's appropriate to discuss pricing. Every patient's different, but you can get your actual price of what it's going to cost you, your out-of-pocket, if you do an MRI review, and we can figure out what needs to be done. One thing I will tell you is this. Let's say you have 2 discs, like you said, that need to be fixed. And we talk to you and say, okay, the price for 2 discs is, price for your disc is going to be this much. You can choose, as a patient, you can say, well, I don't want to do 2 discs, I want to do 1. All right? And I want to do the one that's the most painful, or the one that's the most causes the most symptoms. So you can do that. And we'll do that for you. Like we have people who have 3 discs that need to be fixed. And some people say, well, I only can do 1 disc right now. And we'll do that 1 disc. So we let the patient decide if they want to do 1 disc, 2 discs, or 3 discs. We don't decide for you. We tell you what we think you need, total, and then you decide what you want to do based on your budget, based on, you know, whatever, your risk assessment or risk tolerance for surgery. But we don't tell people what to do. We just advise you. And then you decide. And I can even usually during the interview where we do our telemed MRI review, I can tell you if you ask me, you know, okay, let's say I just fixed this disc, how much pain relief would you expect me to get? And I'm pretty good at figuring that out. Because some discs are definitely more painful than others. I can't do it with 100, you're grabbing too tight. You can't do it with 100% certainty, but I can do a pretty good projection based on my experience. That's it. That's all you need. It's really not how hard you grab it, it's how you grab it. So you got to shove the Raytech into the mouth. As long as you do that part right, then you don't have to squeeze too hard coming off. You're going to get everything out. We're done. Yep. Yep. So I can't see the nerve again because there's too much fat. But that's okay. Fat's good in the foramen. It protects the nerve root and it feeds it energy. Let's irrigate that out. We're going to irrigate now with betadine, and I need the irrigation. I don't usually take the betadine out by itself, so it's irrigation. So just stop giving me just the betadine and then that. Okay. Any other questions? By the way, there's a big piece of herniation right there you might want.
Yes, we have this comes from John Smith on YouTube.
Hi,
Once
John.
more.
Sure.
They asked, this laser seems very appealing. I assume its applications to other injuries in the body would be possible as well, correct?
You know, it's a great question, John. I don't know. So I think you're right. John asked a very good question. This whole endoscopic, minimally invasive idea of getting to an area of your body that is painful and fixing it with a laser. It seems that it could be applied to other types of injuries throughout your body. I think you're right. And it is being applied in a limited sense. For example, now there are now brain tumors being treated with lasers. All right? And they do it minimally invasive like this. They don't use the endoscope to visualize the tumor, but they just use an MRI to guide it. Or they use a navigational platform to guide the laser to the target. So the one thing I know that's very similar, actually don't touch down there. 2 things I know that are similar. Number 1, in the shoulder, people with shoulder injuries, a lot of times the surgeon goes in and basically does a debridement of that shoulder thing. Well, you could do it, they do it arthroscopically. Sean? So, yes, this could be applied to a shoulder debridement, probably very, very same way you do the disc debridement, the Duke laser disc repair. But I'm not a shoulder surgeon. I'm not an orthopedic, I'm a neuro. I've never done shoulder surgery in my life. And I don't know, how to do it. I'm not going to start on somebody, just doing shoulder surgery. But I agree with you. There is other applications. And then, of course, the knee, when you think about the meniscus, is kind of like a disc in a way, because it's a cushion between 2 bones. And meniscuses get torn, just like the annulus gets torn. So I would imagine the knee is probably very similar. But again, I'm not an orthopedic surgeon. I don't do knee surgery. So I can't really say if that's the case or not. But maybe there are surgeons doing knee surgery on the meniscus using a laser endoscopically. And I wouldn't be surprised if there was. As a matter of fact, some of my inspiration came from, endoscopic knee and shoulder surgeons doing endoscopic surgery to fix those things rather than cutting out the knee and doing an artificial knee out of metal. You want to avoid artificial joints whenever you can. No matter how good the surgeon is at putting in an artificial joint, there's always going to be some degree of them being off on the angles. And by being off, whether it's on the length or the angulation, that's going to cause you to walk bad, and it's going to cause you to wear down other joints faster and then have pain in those other joints. So I'm a big proponent of naturally fixing problems in the body, naturally, without putting in artificial discs, artificial metal things that I find are unnecessary. I'm big on helping the body heal its injuries. And that's what the Duke laser disc repair procedure is. We are literally helping your disc heal itself without putting anything in there. So, yeah.
We have another question.
Sure.
This comes from S. Allred on YouTube.
Oh, nice. Welcome back, S. Allred.
They asked, do you plan on working with the Veterans Affairs? Veterans can use this service.
Yes, I would love to work with the VA. We've tried. We've had several VA patients, veterans, that were recommended for the laser surgery. They went to the VA, they talked to the administration. Administration basically stonewalled them. They talked to their politicians, their senators, congressmen. They got no help. So the VA system, just so you know, it's not set up to help people get medical care. It's set up to prevent veterans from getting medical care. I know this. I worked in the VA hospital for years at Shands in Gainesville. I worked in the VA hospital in Gainesville, Florida for 7 years as a resident, okay? And I know how the VA works. Anytime somebody has a way of helping patients more efficiently get care, the VA shuts it down. They don't accept it. They don't allow it. I told this story before. When I was a neurosurgery resident working in the VA in Gainesville, Florida, and the neurosurgery clinic, we would literally have a list of there were 3 residents and an attending. We would have literally 5 patients in the morning. Now, I can see 20 patients with myself. So if you have 3 doctors, you should be able to see 60 patients in the morning. And that's 100 patients easily in a day with 3 doctors. We went to the VA because we were only seeing 10 to 15 patients a day between 3 of us when we should be seeing over 100. And we said, hey, we want to see more patients. We want to help more people, because the waiting list to get into neurosurgery was literally, I think it was 6 months, 8 months. And the waiting list to get into orthopedic surgery was 2 years to get in and be seen and cared for. That was just to be seen. So we went in and said, we're willing to see more patients. Let's make the schedule bigger. Let's add more patients. They came back and said no. It was a shock to us because at the time we didn't understand how the VA worked. But it became apparent that they didn't want to treat more patients, even though the doctors were available. There's no resources used in the clinic, by the way. I mean, whether we saw 10 patients a day, VA patients a day, or we saw 80, it uses the same amount of resources in clinic. So there were no additional clinical resources necessary. But what it would result in is more patients getting treatment they needed, like surgery. Okay? And that's what the VA is trying to avoid. They don't want people getting treatment. Okay? But they don't want to come out and say that, because there would be a national uproar like there was when it actually came out a couple of years ago, right? When it came out and it turned out the VA was actually slow playing veterans care in the news, it was a big uproar for like a week, and then it was gone, buried. You know why it was buried? Because the people in charge of the VA healthcare system are actually the private insurance companies, like Blue Cross, Cigna, United Healthcare. And again, they've been retained and hired by the government because they're managing Medicare. Now they're managing the VA. But they're not called Blue Cross. They have another name. And you guys know those names. I can't remember them. But they're the administrators of the veterans' benefits now. They have special names like, you know, One Star, or I don't remember, whatever they're called. Huh? You guys know? I don't remember. They have, you know, catchy little names that make it sound like they care about you, but they don't give a shit. And their purpose is just to basically deny your treatment. and slow play. So it was the administration at the VA that blocked us from taking care of more veterans. This was back in 2000. This was back in 97, 98, 99, 2000, 2001, 2002, 2003, 2004. I worked at the VA hospital in those years, 97 to 2004. That was 20 years ago, all right? And it's only gotten worse. So veterans, yeah, we love veterans. I want to take care of all the vets, but the VA doesn't want to pay for the surgery. They don't want to pay for any surgery. And the other thing we did when I was there as a neurosurgery resident taking care of vets was we tried to do more surgery. Because the way the VA works is if you didn't have the surgery scheduled, if the surgery wasn't going to start by 2 o'clock in the afternoon, then the VA would say you can't do the surgery. So of course with neurosurgery, these surgeries are long, and that would only allow us to do 1 or 2 surgeries a day. So we went to the head of the VA in Gainesville, and we said, look, we don't mind staying later. We don't mind operating later. We want to help these vets get surgery, but we can only do 2 surgeries by 2 o'clock. And we want to stay, and we'll stay until 8 or 9 o'clock at night to take care of the vets, you know? And we said, we want to be able to do more surgeries. And they came back and said, no, if you can't start the surgery by 2, you're not doing it. And every time we tried to get around them, we literally would sneak a case on after 2, they would cancel it. The anesthesiologist would cancel it. He was in charge. And he had basically orders to minimize how much surgery was being done on the veterans to save costs for the system. So for years, the VA has been cheating our veterans out of health care, the VA system. And you guys don't do anything about it. You just keep accepting it, you know, and letting them do this to you. And then you come to me, the doctor, and say, why can't you fix this? Why don't you take VA? Well, it's not that I don't want to take VA, it's that we don't get paid. And we're doing charity care, and I can't afford it. We don't get any money for charity care. We get no support from our government. We get no help at all. Instead, our government makes surgery almost unaffordable for us to do with all their licenses and regulations and stuff. I'll give you an example. Every 3 years, I have to pay $12,000 to have a government agency come in and spend 1 day here just checking over everything to make sure we're doing everything right, okay? And literally, that $12,000 pays for 1 nurse to show up and review our records. Yeah, my nurses' eyes are popping. They're like, really? Maybe I should do that job. Well, the nurse doesn't get the $12,000, of course. The money goes to whatever, some corporation that's bribed its way into this system. But the point is, $12,000 for 1 nurse for 1 day to review records, it's excessive. It's harmful to the company, right? But that gives you an idea of what I have to deal with financially for our company. And that's just one thing. Everything is expensive in healthcare, and it's made expensive thanks to our government not keeping the cost down. Don't grab so hard. So, you guys need to be aware of the truth. That is the truth. And that might answer some questions for you. It should. It should answer some questions. At least it tells you where the problem is. It's not the doctors, it's not the hospitals, it's the insurance companies and our government, which is now controlled by the insurance companies. Yeah. The insurance companies are not paid like you and I, folks. They don't get paid for doing good. They get paid for denying care. That's how they make their money. Think about it. Let's just take an example of an insurance company, like, I don't know, we'll just pick one, Blue Cross Blue Shield. Let's say Blue Cross Blue Shield every year collects from you, the patients, $10 billion. I'm just going to pick a number, $10 billion a year. That's your premium payments. It's what you pay every month. In 1 year, $10 billion. Now, let's say that Blue Cross Blue Shield gets a lot of medical claims to be paid, right? Let's say that they are very generous and they let everybody get the medical care they need. Well, then they have payments of $12 billion, but they only took $10 billion. So they're losing money. Well, they can't do that. They can't run a business losing money. So what they do is they deny treatment. That's how they keep themselves from losing money. But then it turns out that you can deny enough treatment to cover, have $10 billion in medical claim payments. But if you deny a little more, well, now you've paid $9 billion and you get to keep $1 billion. And that's how it works, folks. The more Blue Cross denies, the more profit they make at the end of the year. I don't know if you guys realize that. And the same goes for the insurance companies that run the VA. They are running the VA benefits now for the government, and they're making a profit whenever they basically deny enough treatment or slow play enough treatment. So, depending on what the veteran system spends, they get their profit. The more money they save by not paying for people's medical care, the more profit they make. These types of arrangements should be illegal, but they're not. All right. Any other questions?
Yes, this next question comes from Marcus on YouTube.
Hi, Marcus. We're just about done here. About 30 seconds left, we'll be done.
And they asked, it looks like the pipe you hammer in goes through the whole diameter of disc, or is it just an illusion from the X-ray sagittal view? I think it's
just an illusion from the X-ray sagittal view. So.
There's another question.
Uh-huh.
This comes from Seriously on YouTube.
Seriously. All right, I like that.
And they ask, how come the healthy parts of the disc don't turn blue of the dye? Is only dead tissue of the disc sensitive of turning blue because of the dye?
That's correct.
Okay.
That is correct. It is only the degenerated nucleus that turns blue. And that's because the dead nucleus is acidic, ACIDIC, acidic. It has lots of hydrogen ions in it, in the tissue, and it allows it to bind the blue dye. That's why. So you're correct that the blue stuff is really staining the damaged nucleus, degenerated nucleus pulposus. When you hear about a degenerated disc, that's what makes it degenerated, is the degenerated nucleus pulposus, which you're seeing as blue, okay? And why does the dye stain it? It just does. That's what it does. That's why we use it, because it selectively stains the nucleus pulposus that is degenerated. When you hear about a degenerated disc, that's what they're talking about. All right, just about done. I don't see any more pieces of herniation. We've cleaned out quite a bit, as you can see, and there's no more herniation there. And the nerve root is right there. Well, it's hidden in that blue. There's a little piece right here I got to get, and that's it. That's just sitting underneath the nerve root. And we're just about done. Now we're done. Those are veins bleeding in the epidural space. Great surgery so far. We got one disc left. Scope off, but we're moving along nice. Hello? Pay attention. Okay, any more questions?
No current questions.
All right, we're done with. We're done. I need the thing. Thank you. Okay, great. So far we've lost about, I don't know, maybe 2 cc's of blood, almost nothing. Remember, if this was an open back surgery, this patient would lose 500 to 2,000 cc's. We've lost 2. So it's basically bloodless surgery. Bloodless surgery, scar tissue-less surgery, no damage to the inside of the body surgery, no need for painkillers surgery, no need for hospital surgery, we're outpatient, no need to stay overnight surgery. So all of this is done minimally invasive through 2 little Band-Aid incisions. And we're on our last one. This is the way to go, folks. This is the best surgery in the world for a disc problem. Sean? You deserve it. If you're wondering, should I pay money to get this done? You deserve it. Your health is more important than anything else in the world. Think about it. If you're unable to work, you're unable to enjoy life, you're unable to care for people that need you to care for them, what's the point, right? So the whole point is that's why health is so important, is so you can actually do things. And chronic back pain robs people of their quality of life. Those people with it understand. And everybody with back pain, by the way, is in a spectrum. They're on a bell-shaped curve. And what I mean by that is the people with kind of new back pain that comes and goes every once in a while, well, they're having back pain every once in a while. They're eventually going to advance, Sean, to having back pain every day and constant. So the spectrum is, in the beginning, you have back pain with, well, now we've lost 5 cc's. In the beginning, you're going to have back pain once in a while from a disc problem. And then over time, the back pain gets to be daily. And then over time, it gets to be constant. Shot? All right, we're watching the tube go in, and it looking good. I think that should be it. All right. So that last disc had a little more blood than all the other discs, and that's fine. It's probably coming from the opposite side through the disc. That happens when you're doing bilateral. Very good. So we're on our last disc. We've already fixed 5. We're on number 6 right now. And you can see this has been done on both sides with a 7mm incision. All right, any questions from the audience? Because we're just about done. Probably another 10 minutes.
Yes, this next question comes from Brian on YouTube.
Uh-huh.
And they ask, when the access tube and laser create a cavity in the disc space, does this create a risk of discitis or risk of instability in the future?
So when the tube goes into the disc space, does that create a risk of discitis or instability? So the answer is yes. Anytime you are entering a disc, you can get discitis. And discitis is inflammation of the disc, most commonly due to infection. But if you remember, I said earlier, we've never had an infection. So we've never had a discitis from our surgery, okay? So yes, in theory, this could cause discitis, but in over 1,600 surgeries, and each surgery, by the way, we repair on an average of 2.5 discs. So that's 1,600 times 2.5. What is that? Over 5,000 discs that we fixed? So over 5,000 discs we fixed with this technique. We've never had a single infection or discitis. So I guess you could say the chance of getting a discitis is less than 1 in 5,000 discs. So I don't know at what point you would say, no, it can't happen, but pretty darn close. Yeah, Thanks. Then, as far as instability, what is instability? People don't really understand what instability is. This surgery fixes instability. If you understand what instability is, you'll learn that this surgery is the cure to instability. So the first people to describe instability, the definition that we all agree to, is by White and Punjabi. They're two orthopedic spine surgeons, and their definition of instability is debilitating pain or neurological deficit that comes from a disc when it's under normal physiological loads. So think about that. Normal physiological loads, that means doing normal daily activities, and that's horrible pain and nerves being crushed and damaged, causing nerve damage. Well, this surgery fixes that pain, and this surgery unpinches the nerves. So it actually stabilizes the spine. That's what this surgery does. It goes from an unstable spine to a stable spine. So this surgery you're watching stabilizes the spine. Quite the opposite of unstabilizing the spine. Now, other types of surgery can also stabilize the spine, but at what cost? When you're having a fusion, you're getting all that metal put in your back and you're losing your movement, your natural movement. Plus you have all the complications that happen with fusion. They just published the results of cervical fusion. Complication rate is 50%. That means 50% of every patient with a cervical fusion has complications. So we have 0 complications with this surgery. Which would you rather have, 50% or 0? I know which one I want. I don't want to go have surgery and have a complication. Complications are bad. You can die from complications. That's why any surgery that has 0 complications, like this one, is a much better option for you, the patient. And by the way, the doctors aren't going to tell you that. Doctors aren't going to scare you out of your surgery because of the potential of complications. They're going to minimize the complications. They're not going to talk about them. They're going to let you figure it out on your own. They don't say to you, by the way, there's a 50% complication rate with this surgery. Right? If they did, even fewer patients would have surgery. Then they'd have a harder time making their payment on their Mercedes. Okay? So, complications are serious, they're real, and they do happen with spine surgery. And the more invasive surgery you take, the more complications or risk of complication you have. Okay? Nerve damage, spinal fluid leak, infection, hardware loosening. I have a patient I saw in clinic yesterday. She had a spinal fusion done by another doctor, and the screws are loose, and she can't even stand up, and she can't even work because her back hurts so bad, and her legs hurt so bad. The screws are loose. It wasn't my fusion, it was somebody else's fusion. But now I'm the one she's coming to get it fixed, right? So I'm going to have to go in and probably take those screws out. We're going to have to get permission from her insurance company, but that's a surgery coming up. We are doing a fusion next week if you're interested in watching. It's a lumbar fusion, and it's in a patient who is wanting a fusion. So, I mean, I tried to get them to do the laser surgery, but they said, no, I want a fusion. We do have occasional patients like that. They're misinformed, and they're putting themselves through a surgery that is far more invasive and dangerous to them. But in the end, I always respect what my patients want, and if I can perform it, I'll do it. And by the way, I do a better fusion than anyone else I know. So I've even written papers on fusion that have been peer-reviewed and published in the medical literature. I'm one of the few fusion surgeons that have gotten really good publication on fusion. So I'm perfectly capable of doing fusions. I just discourage people from having them because they're so invasive. Now, have I done fusions with 0 complication? No. My fusion complication rate, when I published, I think it was 2%. If you go to PubMed, I think we had a infection or a couple of infections, and we had even one patient die, and not during the surgery, afterwards, and that was from overdosing on narcotics. I'll never forget that patient. He was a firefighter too. It was sad, and he was in so much pain after the fusion, which everybody is, by the way, and he somehow managed to overdose on his narcotics. So that happens. People do die. It's real. It's not made up. In Florida, 25 people every single day die from prescription narcotics given to them by their doctor for pain. I've had one in my own, and it was the saddest day of my career. It was many years ago, but in the end, you're giving a patient a bottle of death. That's your pain pills. And you're saying, if you take the wrong amount, you'll die. So please don't take the wrong amount. You hope to God they have somebody responsible with them. But when a patient, when a patient has access to those pills, those narcotics, they can easily convince themselves to take more, and then next thing you know, they stop breathing and they're dead. And this was before Narcan was readily available. But yes, I've had one patient in my entire career die, not from my surgery, but obviously from the pain after surgery. It was about, I think, 3 or 4 days after the surgery or a week after surgery. So I still am responsible as a surgeon. It's my patient, and it's as a result of my surgery that they were overdosed. But I take responsibility for those things. Other surgeons don't. They're not going to talk to you about the risks of their treatment. Okay, but you need to know the truth, because it could be a life or death situation for you. I remember, I'm a scuba diver, and I love scuba diving. I've been scuba diving for almost 40 years, or maybe more than 40 years now. I can't remember. It's been a long time. I think I started in 84 was my first time diving, Club Med, 1984. And long story short, you all hear scuba diving is pretty safe, and it is, but there's some things that can happen to you while you're scuba diving that could put you in a life-threatening situation. And it's not sharks, by the way. It's basically human error. And we were diving, my wife and I, in the Caribbean with a large group of very good divers, a good dive master, a good captain. But the seas became very rough while we were down. And I always do my own navigation. And the current had swept my wife and I far away from the boat. And when we surfaced, we were probably 100 yards from the boat, but there were swells on the ocean surface. There was a big storm that blew in. So there was a current, and there were swells, and there was a surge. Surge isn't a big problem, but the current is. And I guess the tide was going out at the time, and it was very strong. So it pulled us away from the boat. And I'm a very experienced diver. I'm an advanced expert diver. My wife, she was not at the time, but she was with me. And we surfaced and we signaled to the boat that we were okay. And, they saw us, and then they were loading the other divers who were with the instructor. And there were about 20 of them. They had to load them first before they got to us. So we decided to swim for the boat. And as we were swimming, we realized we were not making any progress. We were actually floating further out to sea. And I told my wife, listen, you gotta kick harder, right? I was doing almost maximum. And I realized if I went maximum, I'd burn out. And then we both float out. So despite our best efforts, we kept floating out, and we were about 250 yards away. And, we're out in the middle of the Caribbean, right? And this is a captain of a boat who, who knows how many divers he's lost in his past. But if it was me, I wouldn't lose a single diver. But not everybody's me, right? And, it goes along with diving, is that you may end up dying during diving, and that's just something we all accept. So I wasn't willing to bet my life and my wife's life on our captain caring enough to come and find us. So I put our bodies into hyperdrive, and I scared the bejesus out of my wife. Said, we're going to die out here if we don't get going. And we got lucky and we made it. But the point is, even scuba diving, something that you think is safe, something that you can't really die with, people die. They die. And surgery, spine surgery is, wow. I mean, people die with spine surgery all the time. So if you want something safe, if you want the safest surgery where you're not going to have a complication, this is it. Duke laser disc repair. Safest spine surgery in the world by far. And if you want effective, this is it, right? This is the best. We get rid of the most back pain and the most leg symptoms of any surgery. And there's no metal put in your body. So it's just a win all around. You're back to a normal life very quickly. All right, we're done. Go ahead and type up your questions for me, and I'm going to come answer them for you face to face. All right? I'm going to answer them for you face to face. But we're pretty much done here. A little more cloudiness of the water, that's from the blood. And that's nothing bad. We haven't lost much blood at all. We've literally lost probably at most 10 cc's of blood. So 10 compared to 1,000, which would be what you'd expect to get from an open back surgery to fix the same problem. Okay? Type your questions up. I'll come answer them for you. And we're pretty much done here. We're going to put a little antiseptic, and we're done. So type your questions. If you know somebody suffering with chronic back pain or neck pain, fill out the MRI review form. I'll be happy to do an MRI review, tell you what's wrong and how to fix it. I'm going to show you here. No, come on, man. Oh, damn it. Have you not noticed I do things the same way every time? There's a reason. I figure out what the best way is and I do it. All right, Henry, you want to show them the incisions, and then we will cut to a testimonial. Can you guys see this? You, the audience, can you see how small the incision is? This is a 7 millimeter tube, so that's how big the incision is. 7 millimeters. I'm putting pressure on the muscle. I don't want any bleeding into the muscle. Bleeding into the muscle can cause muscle spasms, which we do get from time to time. And patients will have prolonged muscle spasms for like weeks because if they get too much blood in their muscle. So I do what I can to prevent that. We keep the blood pressure down. We minimize, the use of anti-inflammatories and things that make people bleed before surgery. We also make small incisions, and we do everything we can. I put pressure on the muscles. So we're doing everything we can to minimize the risk. Go ahead and open them. Open up the covering we're taking off is called Ioband. It's an expensive covering we put on our patients to help prevent infections. A lot of doctors won't use it because it's expensive, but we spare no expense. A stupid thing. With our patients, we want our patients to have the best care. The problem with the Ioband around your thing is that it blocks the blood from being absorbed. That's why we don't do it that way. Okay?
Yes, sir. Oh, I see that.
Yeah, it's that way every single case. You need it like this. If you want to do anything, put a rubber band. Okay, so let's take a look. All 6 discs were fixed through 2 7 millimeter incisions. Well, this one may be 8 or 9, but that's it. Can you see that, Henry?
Yes, we can.
Let's put that on his testimonial clip so everyone can see it.
Copy
Thanks, guys. Good job. We're going to close up now, and we're going to have another surgery. Our next patient is going to be thoracic, I think, right? Last one. So the next one's a single level lumbar, and the last one's a thoracic with the DPR on top of it. Great. All right. Well, type up your questions. In the meantime, we're going to run a testimonial from one of our patients who had the surgery so you can share their experience. And good morning, I'm Dr. Duke Machen. I'm here with one of my lovely patients from Canada who has visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years.
Yes.
Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair endoscopic surgery. And you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was, you said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only a 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, and that's end goal, and I feel like it's a possibility now.
Absolutely.
Do it.
You can.
Yeah.
We're rooting for you.
Mm-hmm.
And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's it's very hopeful, and if there's you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports in the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right.
Thank you so much.
Congratulations.
Thank you.
All right. Take care. And I'm Dr. R. Duke Machen here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to
I'm
help
happy.
you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my
So you
community.
want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith,
I
and
am.
you found us.
Yes, I
and
did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do
good.
for me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming, because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Well, I hope you enjoyed hearing from one of our patients who had the Duke laser disc repair on her back. And, you know, the thing about this surgery is that it gives consistently good results. Think about your best restaurant. Think about the best dish at the restaurant that you love to have. Think about that. Every time you go to that restaurant, your mind is set, your body is set on having an experience that's consistent. You want that same dish with that same experience. We've all seen Ratatouille, and we remember the rat and how it made that special disc for the food critic, right? Cute movie, but it drives home an important point, and that is the food critic, who was a miserable character, right? Kind of like people in back pain all the time. He was miserable because no one had been able to recreate that experience for him of having that one dish, Ratatouille, prepared for him the way his mother did it when he was a kid. And this rat, this special rat, had figured it out and made it perfect. And that's what the whole movie was about. And it's a beautiful story if you like those types of stories. But it emphasizes what we do at Duke Spine. We have found the cure to getting back to life without back pain. So rewinding the clock, going back to your childhood, to when you didn't have back pain and you could do whatever you wanted to do. That's what Duke Spine offers people. We're the only ones who can do it, just like in the movie Ratatouille, Remy the mouse, the rat, he was the only one that could recreate that dish for the art critic, and he did it. So we want to bring people together to pleasurable experiences. That's what we want to do at Duke Spine. And we're able to do it through our surgeries and our treatments that are unique. They were developed here, and no one else has them. They do similar stuff out there endoscopically, but nobody does what we do. Nobody has the results that we do. All right, first question.
First question comes from Seriously on YouTube. And
Hello, seriously. Thanks for asking.
they asked, I'm from mainland Europe in the Euro region of Netherlands, Germany, Luxembourg. Have you ever received an MRI from someone in mainland Europe? And have you ever operated on someone from mainland Europe? And was it possible for this person to pay this operation through their national health service and insurance?
So, great questions. First of all, thanks for joining us. We're glad you're here. Yes, we've operated on many people from Europe, Asia, Africa, all over the world, Australia. People come here for this surgery. 80% of our patients now come from out of the area, out of this Florida. They come from other states. They come from other countries. Canada, South America, as far away as Australia, Africa, South Africa. I mean, we've had people from all over the world, even Norway, even Sweden and Finland. We just had a patient from Switzerland last week on Thursday. She's in finance. She works for the Swiss banking system, and she did not do a testimonial for us because she cannot because of her work. But she had 100% of her pain gone. She traveled all the way from Sweden. From where is it?
I thought it was Stockholm.
No, it wasn't. It was Geneva. Sorry, Geneva, Switzerland, not Sweden. Long story short, we can help you. We can definitely do your surgery and fix you, and then you can go home and be pain free. As far as whether the national system will pay, I don't know. What we do is we collect money from the patient, and then the patient will submit the bills to their national insurance and hopefully get paid. But we don't bill the national insurance for you. You would take your receipt for what you pay and you would take it to the national insurance. I don't know whether they'll pay or not. I can't promise you they will, but I think it's worth doing. Next question.
That is it for questions.
All right, well, that's our only question. I hope you enjoyed the surgery. We are going to move on to the next surgery, which is a patient who has a bad disc at L5-S1. It's a bulging disc. It's not even a degenerated disc, but a bulging disc, and he's having back pain right from L5-S1. So we're going to go in with the endoscope and laser, and we're going to test the disc with the discogram, and then we'll do the Duke laser disc repair on the annular tear. Feel free to type in questions, and if you know somebody who's suffering from back or neck pain, feel free to use our MRI review system. It's MRI@dukespine.com. You can go to our website, dukespine.com, and you can look for the free MRI review. Just type in your information and send us a copy of your MRI images so we can look at them. Don't try to do copy and paste of your report or anything like that. We need all the images uploaded, and these are DICOM format images off your CD, or just send us the CD by mail. All right? Thanks for joining us. Have a nice day, and we'll see you soon for the next surgery. And our last surgery of the day will be a thoracic Duke laser disc repair.